Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Welcome to today's webinar. PYA understands the importance of clear, relevant, timely information to the industries we serve. So we offer a variety of webinars, white papers, articles, checklists, and other tools, all for free. Subscribe to our e-newsletters, follow us on social media, and subscribe to our PYA Webinar Recast podcast series for audio-only versions of all of our webinars at pyapc.com. Thank you for joining us. Here are today's presenters.
Welcome to episode 6 of PYA's Revenue Recharge series. Episode 6 is going to address value-based care. My name is Jane Jerzak. I'm a principal at PYA. I'm joined with my colleague Martie Ross from PYA as well. And we're going to be walking through the key attributes of value-based care, what's important, what should you be concerned about with respect to this important topic. This is episode 6 of a 7-episode series on improving the revenue stream, the revenue opportunities for your organization, as well as becoming more knowledgeable about alternative payment models. The last episode, episode 7, is going to be airing on September 19th, and that's going to be addressing other revenue opportunities and really summarizing the first 6 episodes. So welcome to the webinar. And Martie, I'm going to invite you to begin to introduce value-based care to us.
Great, thank you, Jane. Let's just start out with this concept. Oops, sorry about that. Let's start. What do we mean by value-based care? And really, it's best understood in a juxtaposition to today's existing fee-for-service methodology of payment. That currently providers furnish a service and get paid for a service, and generally without regard to the quality of the care they provide or even the efficacy of the services. Now, payers will attempt to regulate in a fee-for-service environment by imposing medical necessity requirements or prior authorization requirements to ensure that, in fact, the service is appropriate. But the idea of moving from fee-for-service to value-based care is that by changing the incentive structure, by creating a financial reward to providers that deliver high-quality care in an efficient manner, that we will actually improve health outcomes and thus reduce healthcare costs. There's really no cap on spending in a fee-for-service world other than regulation by the payer. But instead, by creating the incentives for the providers to pay them for delivering quality, we actually end up reducing healthcare costs. Now, in 2015, a group of public and private healthcare leaders formed a group that's known as the Healthcare Payment Learning and Action Network. And this group promotes the adoption of alternative payment models, value-based care. And one of the first projects they worked on was developing a common nomenclature for discussing what is value-based care so that we could then measure the industry's progress in adoption. And what you see before you on the screen is the categories that were identified by what we call the LAN, the Learning Action Network. Category 1, just describe that, fee-for-service, no link to quality or value. We transition into category 2, where it's still fee-for-service, but we're going to have some variation in payment based on quality and value. So let's start with category 2A. Those are infrastructure payments. So if you think back to 2009, 2010, the rise of the Meaningful Use Program, where there are incentive payments for hospitals and providers to implement electronic health records. That would be a category 2A payment. Then we have pay for reporting. So this, again, incentivizing providers to track their performance on quality measures and report that information. think of, for example, the hospital inpatient and outpatient quality reporting program within the Medicare program. Those are examples of pay for reporting programs. Doesn't matter how you perform, it's just the fact you deliver data to us that we're going to give you a payment for it. And that again evolves into category 2C, which are pay for performance, bonus payments that are directly tied to how you perform on identified measures. So think of the merit-based incentive payment system, or MIPS, within the Medicare program. That's an example of a 2C payment. Now the next big leap from category 2 to category 3 is we really start thinking of true alternative payment models. Category 3 models are defined by the fact they're built on a fee-for-service architecture. So providers continue to receive fee-for-service payments, but we overlay that with a structure to change the incentives towards quality and efficiency. 3A are shared savings programs where there's no downside risk. So in a shared savings program, we assume a benchmark, what the payer would expect to pay absent no intervention on the part of the provider. And if the provider is able to lower costs below that benchmark, then they're going to share that savings with the payer, creating that incentive to lower the total cost of care. Generally, shared savings programs are overlaid with quality measures that you have to report on certain quality measures, achieve certain scores, and that will determine the percentage of a payment of the shared savings that you receive. The next step then is category 3B, and here we begin to introduce the concept of risk. That if a provider, for example, go back to that benchmark, if this expenditures end up being above the benchmark, there's an expectation, an agreement between the provider and the payer that the provider will pay money back to the payer, meaning they'll take on the risk of increasing expenditures, not managing that population appropriately. And here you really begin to see the incentives changing in the provider community because they are, in fact, have skin in the game. That then takes us into category 4, which are population-based payments. So now we are truly breaking the dependency on fee-for-service reimbursement. We instead are, for a provider group, we're defining a certain set of services that they are to provide for a set amount of money. So you could, for example, have primary care providers who are paid a capitated amount for delivering defined primary care services without regard to the number of services provided. They're just manage that patient care appropriately. And then you eventually get into population-based payments where a health system, and not in today's definition of a health system, but truly a network of providers, a continuum of care, receive a population-based payment. You're taking on these lives, we're going to pay you this much to furnish all the services that they require, or potentially we X out certain extraordinary expenditures from that population-based payment. And really that's the end game. That's where this transition to value-based payment is going. So a very handy framework for kind of comprehending the steps and the development away from fee-for-service into value-based care. Now, LAN then takes it a step further, and since 2017, they have been conducting a really broad-based survey using payer data from multiple sources to define where the industry is in this march forward towards value-based care. And what you see on the screen are the results of the 23 survey based on 22 data. LAN releases this report generally every October and November, so this is sort of the tail end of the current data. And really, for the last 3 years coming out of the COVID-19 pandemic, these numbers have been pretty steady. They've seen some movement in the numbers, but not that significant. And what I really want to call your attention to is the risk versus no risk, because we have about 25% of payments from all payers are running through what they call a category 3B or 4, a risk-based payment model. That means 75% of payments are still in a traditional fee-for-service, maybe with some adjustments attached to it, but still that dependency on the fee-for-service. But more interesting than this is aggregate to the entire industry, all lines of business. But let's talk about and we'll talk about 4 lines of business where they are in this transition to risk. The high end is Medicare Advantage. that they are just under 39% of payments in MA run through a risk-based arrangement. Next up is just traditional Medicare. They sit at about 30%, so about 10% lower. Next up is Medicaid, that sits at about 19%. Who's bringing up the rear? It's commercial at 16.5%. They're the last to move towards adoption of these methods that are intended to save money. Now, this creates some tension because what we are aware of is that a growing pressure from commercial buyers, right, employers that sponsor these health plans, incredible pressure to reduce their costs. That we have here an example of a report that was published back in 2021, but certainly still true today, that we have decision makers at top corporations say that this just is not sustainable, that we cannot continue to pay these kind of rates. And in fact, they expect or even want government intervention to try and bring some sort of cost control into the market. In fact, this is even more current. Last week, there was a report that came out of a consulting firm called Aon. They expect employer costs to go up 9% over the next year. So if in 2021, we were saying they aren't sustainable, and now looking into 2025, we're going to hit a 9% increase, then it's even becoming worse. And then you may be familiar with a long-term study done by the Rand Corporation that specifically focuses in on hospital prices and compares what commercial payers are, the rates paid by commercial payers as a percentage of Medicare rates. And what they have found is that on average, it's 200% plus being paid by commercial payers. And their concern is, if Medicare should be the standard, why are commercials being expected to pay so much more? And their bottom line recommendation is that employers should be looking for price concessions or excluding what they call high-priced competitors from their market. So what's here and what you have to appreciate is these attitudes still hold on to fee-for-service reimbursement. We're focused on per unit costs. And how do we start changing that conversation to per employee expenses, or what we pay as a whole to provide care? So for that insight, I'm going to turn this over to Jane.
Thanks, Martie. If we take a look at how payers have responded to this, and by payers, we really want to bifurcate it into really the true purchasers of healthcare. And if we focus on that commercial market, those purchasers are the employers. And then the other side of the coin are the true payers as we know them today, the Uniteds, the Anthems of the world. So let's look at from the employer lens. What are they hearing? Well, as Martie said, they're hearing about high cost, and their recommendation is to simply have price concessions, try to get the cost lower. What you haven't heard them talk about at all is quality. You haven't heard them talk about how they're managing care of their employers. It's almost like that's still assumed to be reasonable or fine, and cost is king. So from the purchaser, the employer lens, when they hear this, I think they throw up their hands and they say, we have very limited options. They're really not too versed on value-based payment opportunities, meaning increase quality, lower the unit cost, better manage population. They're really unaware of those types of programs. They don't really have access too much to payer price transparency. And let's face it, if they do, it's extremely confusing based on how hospitals and health systems and physicians are getting paid today. It's complicated. They just don't know how to evaluate quality of care. It's usually anecdotal from their patients, their employees. They're unwilling to accept narrow networks as a potential of better tightening the management of care for their employees, because their employees don't like narrow networks for the most part. So they're really reluctant to really embrace narrow networks, roll up their sleeves with a health system that may be innovative, and really try on a program that could provide more value for less cost on a long-term basis. There hasn't been a lot of growth in on-site clinics, near-site clinics. So that's been very reluctant. Maybe for large employers, it's worth it. But for the smaller employers, it's very difficult to undertake that. So from the purchaser's perspective, I think they're throwing up their hands and saying, we really don't know what to do next. We don't have any influence over cost controls to a large extent. Now, from the payer perspective, the Uniteds of the world, Cignas, etc., they're posting record profits. Why is that? Well, they have been successful at two things in the recent past. They are curtailing the utilization of care. We're all been there in terms of prior authorization, post-payment reviews. The amount of care payers are willing to pay for is really shrinking. They're reducing inpatient care to an observation stay or outpatient. They're limiting high-end ED visits. They're reviewing things. So they're limiting the amount of care and they're limiting the price per unit. They've been very, very reluctant to raise prices or reimbursement for providers by more than a few percentage points the last number of years. So lower cost per unit, lower number of units, while they've continued to sustain increases in their premiums, they've got record profits. They've got record profits. They're continuing to blame providers for high healthcare costs. And really, this isn't fair because if you think about where those profits are coming from, clearly they're on the backs of the provider community. So let's talk about the key payer strategies. They have increased the number of plans that are offloading costs to employers, the high deductible plans. Good for them. When you think about how a claim is processed, if they owe the provider $100, but yet the high deductible plan requires that whole $100 to be paid by the employee, they pay zero, they wash their hands and say, you have to collect it from the employees. Oh, we all know how challenging that is. Aggressively negotiate price concessions. They've got market power. There's maybe 2 or 3 dominant payers in the market, and they have used that to gain very powerful price concessions in the last number of years from providers. Lowering reimbursement rates, even on Medicare Advantage plans. The rates are less than traditional Medicare or on some services, all under the guise of incentives if you improve quality, but basically the incentives are nothing more than a withhold on some of what they owed you from a regular traditional Medicare reimbursement standpoint. So they are very aggressive in negotiating price concessions. And they're also imposing more and more utilization controls on providers. We've all seen the payment or the provider policy manual grow and grow. And all of those provider manuals are increasingly reducing what's actually paid for. And if it is paid for, there's some pullbacks, there's downcoding, and they're not authorizing a number of services that should be authorized. So these typical payer strategies, when you think about where we are today without value-based care, the impact on these strategies on providers is huge. It's just a no-win for providers. Again, lower per unit reimbursement rates, as Rand was reporting, as Marcie shared, we're moving more and more closer to Medicare rates for commercial payers. The volumes are reduced on some very high fixed cost services, which is creating lower profitability for our provider community. Not to mention the increased administrative cost and burden of all this prior authorization, physician time, RN time. There's just a lot of very high cost time that's not adding one penny of value to patient care. Reimbursement less than allowed amounts. When we take a look at what this is really doing to the providers, when we measure what should have been allowed versus what was actually reimbursed, that gap for our commercial population can be 8 to 9% of the expected reimbursement. In some cases, we see that gap is 15%. Why is that? Part of it is the payer behavior for what they want to pay, as we've been discussing, and part of it is what the employee portion is not paying. So when you roll those things together, the provider community may be getting 8 to 15% less than what they were expecting their plan to say. So clearly, this is a no-win for the provider community. So we believe we have to embrace value-based care as an alternative to these schemes that you're seeing from providers or other payers. So if we think about what possibilities providers have on this continuum for value-based payment strategies, we see a lot of opportunity here. And number one, what we believe is possible is for you to do pilot programs on your own employee health plan. It's your employees. You can create incentives to add prevention measures, encourage the use of primary care services with no co-pays, PT services with no co-pays, all things that are high value, high satisfaction to your employees that avoids, hopefully, surgical procedures, hospitalizations, high cost drugs. It's a perfect population as well where we can measure. We can measure the cost before these programs, after these programs. We can measure in-network use. We can measure the cost of drugs that were on formulary, that weren't. In a nutshell, it's a perfect learning lab for you to create an opportunity for telling the other payers there in the future, the employers in their market, what you could do to their health plan for their employees. Prove to the community that you can do it with your employee population. So that's really exciting. That's step one. Step two, and really a concurrent step, is deploying competencies to succeed under these payment models. And really the first step here, we believe, is a team-based care model to manage different populations, manage the cohort. Invite patients to call the team nurse with any questions, not to go to the ED, not to have that potential admission or readmission. Really engaging with payments on this open access welcoming model. You're really adding to their health literacy. You're creating metrics, you're measuring, you're doing things that are really helping, improving to manage the total cost of care. You're also developing care pathways, and you're integrating care between primary care and specialty care. The rules for referrals to key specialties are really a key for common conditions. You should be developing rules for when to refer headaches to neurology, when to refer allergies to an allergist, when to refer care for endocrine from diabetes care. A lot of these things can be managed very safely in primary care with algorithms and care pathways, and keeping the open access system for specialties so that when people truly do need that specialty care, they can get it. They're not clogged with unnecessary referrals. And certainly a tracking system. You need to track care gap closures, integrate it with your electronic health system. There's all kinds of competencies that are needed to be built. But guess what? Those competencies can cross populations and they can add value to your whole enterprise. So that's number two. Once you develop those competencies and you prove that you can do it with your employee population, you can prove it with data, both metrics, qualitative as well as quantitative data that things are working, and you've got your teams in place and the incentives aligned, then you can start offering employees meaningful opportunities to engage with you directly and use the traditional payer simply for processing claims. You can then be innovative with those employers. You can toggle between what's provided on-site, off-site, and you can really shift the gear toward preventative care, care literacy, and really with the hopes of reducing those high-cost procedures. So that's really exciting. And then lastly is number four, really creating and starting on some shared savings models with payer contracts, with upside risk, so that you can safely understand, is the data the provider is using accurate? Does it align with your data? Do you feel that the savings that you are garnering, you are fairly sharing in them? Is there a payment for managing the population health that might not be tied to a CPT code? Is there a per member per month element for that? So that you can really ensure your current your success with these models on the glide path. And then lastly, that you make sure that your current success doesn't get counted against you in future years as new metrics are becoming developed, so that you really want to share continuously with the payers and you don't want it to be, in a sense, a one and done. So lots of opportunities for providers. And I think, Martie, as we really roll into this and summarize it and just have a dialogue about this, we're believing that providers must move off of that level one contracts with no incentives toward level 2C and really even into level 3 in order to invest in some of these programs that improve the health of the population and get paid for it. Because today, again, we're seeing more and more shrinkage on what you're even getting paid from those providers, and we're getting closer to Medicare. And we all know Medicare reimbursement does not cover the total cost of care.
Yeah, I think back 10, 12 years ago, Jane, and some of the folks that were on the bleeding edge of adopting these models, it was usually resistance from the finance folks who would say, no money, no mission. You know, we have to be able to keep an adequate margin rather than, you know, focusing on these clinical improvements that you discussed. And really, you have to see the evolution in the market, that what you're going to continue to be pushed down on are price. And if you don't have an alternative to offer the market, if you can't say, hey, we can take on this population and we can provide care within these, within these dollars, it's going to reach a point where the system does break. And when it does break, what are the alternatives? We're talking, you know, employers are saying they're ready for price controls, federal price controls, which is not going to be delivering the quality of care we want to see. And so really this goes from a clinical imperative to a financial imperative. And yes, the clinicians will embrace this. This is the way they want to practice medicine. We just need to enable them on the finance side.
Exactly. And that goes with in the investment. And as you work with employers and as you work with payers, this concept of per member per month care management is critical, because you as a provider community are investing a lot in technology, infrastructure, learning, care coordination programs. That's got to be paid for somewhere by someone in order to make it successful. So really, this imperative is suggesting to you as providers to take the lead on this in your community. We got done discussing with you that there's little, if any, incentive for the payer community to do this. There may be some incentive for the employers to do this, but they don't know how. So you as a leader in the community in healthcare need to take them by the hand and say, we can do this together. We know how to do it. We've piloted our employee health program, and we want to do the same thing for your employee community.
Yeah, I remember my Econ 101 class from college, and they said, the system works best as closer the consumer is to the producer. And I always ask people, who's the consumer in healthcare? Is it the employer? What is it the processor, the payer, the Aetnas of the world? Is it the employer, or is it the actual patient? And we're 3 levels removed in healthcare from the person we're actually furnishing the care to. Value-based care is about breaking that down and getting it back to the patient and the provider and that economic relationship and aligning it correctly.
Exactly. And the side benefit, of course, is really redesigning care delivery at that provider, right at the elbow of the provider, adding support, having people work at the top of their license, really deploying RNs in a much different role than they ever have, deploying diabetes coordinators, putting pharmacies into the clinical environment, incorporating behavioral health, all those things that make great sense for high value care.
And all of those things you're saying right now aren't paid for under a fee-for-service system.
Exactly.
So it's a significant realignment. So.
Exactly. Excellent. Well, thank you so much, Martie. This puts closure to our value-based care discussion, and we're certainly thrilled that you joined us today. And we'll remind you once again of session 7, which will be on September 19th, and that will be kind of a wrap-up of the first 6 sessions, as well as really adding new content. And if you want to go back and listen to any of the previous content, they're certainly online at pya.com, and we're sharing the link with you on this slide. Thank you so much.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us, and have a great rest of your day.